I see Rajneesh to present my nightmare situations with stenosis aortic valve, managing it with for forgiving valve. Rajneesh, over to you.
Yeah, thank you. It's always a privilege, presenting in front of you. And thanks to the Hyderabad Live organizers, especially to Dr. Sarat Chandra for having me here. So we never thought 6 months back that we'll be doing all this stuff on e-conferences, but pandemic is really teaching us a lot of things. So just continuing the journey further, the TAVR is picking up in India. Obviously, we have done quite a number of cases in last year or so. Personally, I have done around 35 TAVRs. So not really the nightmare. So I'm just taking you through that what could be the issues once we plan a case or execute a case of TAVR. So this is the current situation in India in 2019. So still at the moment, there are around more than 25 centers doing TAVRs in India, but majorly it's the 5 centers which contribute more than 75% of overall cases of TAVR in India. Another difference, which is quite a significant difference as compared to the Western thing, that there are much more bicuspid valves where we are doing TAVRs. So our bicuspid valve TAVR experience is much more as compared to a Western population. And so we are pretty confident and comfortable while dealing with such hostile valves. And 96% of the cases in India practically are done via transfemoral access. There are few which have been done through transsubclavian, obviously where the femoral access have been really hostile, and very few have been done alternatively through a direct aortic access. So this is data for TAVR last year, 318 TAVRs done and 240 were self-expanding, which is actually is more significantly done with self-expanding valves rather than by balloon expanding. But now I think balloon expanding reached Indian market later than the self-expanding, so they're picking up. The common anatomical issues, the complexities which are there while we are planning a TAVR are under these heads, that it could be a very densely calcified valve, it could be a very dense annular calcification, or hostile landing zone with LVOT calcification. So these can increase the hostilities while we are dealing with TAVR in such valves. The constrained anatomy, the constrained valvular and the ascending aortic anatomy is always an issue in some subsets. The low coronary ostial heights. In fact, these two, once we amalgamate these two complexities together, this become more hostile. The constrained annular root and ascending aortic anatomy along with the low coronary ostial height, horizontal aortas and compromised vascular access. So we have to be really careful while planning a TAVR case in such scenarios. So I'll just take you through to few cases which I have done. As I mentioned, really not a nightmare, but yes, we require to be very, very cautious in certain situations like this. First patient was 79-year-old male patient, had a severe LV dysfunction, had a prior bypass done about 10 years back. So now presented with a critical aortic stenosis, considered as a suitable candidate of TAVR as the patient was really a high risk for surgery. These are the parameters. The annulus was okay. And this is the sinotubular junction. Sinus of Valsalva is quite spacious. Sinus of Valsalva height and coronary ostial height again is adequate. So parameters look very clean up till this point, but it was not the case. So if we are looking at the valve only, the parameters may be quite handy and quite friendly, but then there could be other issues which come up during a case. So simply may not be an easy thing. We have to look it in totality. So now look at the aorta. It is a heavily calcified aorta, porcelain aorta almost. Annular calcification extending into LVOTs, and on top of that, the femoral access or the subclavian access, they were very hostile. We had a dissected right iliac artery. It's not femoral, it was totally dissected from the right iliac down. So obviously right was not the favorable access for us. And even the left iliac and the left femorals were calcified and quite angulated. We thought of alternative access. We thought of subclavian. Subclavian access was again not a possibility due to a low size. It was less than 5. And to add to the further things, the coronaries were not really great. As I mentioned, patient was a post bypass, and this is the saphenous vein graft, which was at the anastomotic site very tight and a distal diffuse LED disease. But at the moment, patient presented with the critical AS and symptomatic, so we thought that we'll continue to manage the aortic stenosis with TAVR first. So although the access was hostile, we thought we'll go from the left femoral route. It was not that bad as compared to the right. So our preference was the left femoral. And this is the echo and this is the procedure. The pigtail aortogram done, PPI in place. And this is the lower down picture. We can easily see the common iliac on the right side looks very hostile. It was all dissected down. And on the left side, it's not looking that bad, but there is a big chunk of calcium at this angulation, almost at the ostium of common iliac. So we face a lot of problems here. Up till this point, it was all going okay. But once we were going with the valve sheath, we faced a lot of difficulty. We were unable to actually maneuver across the iliac. And it was not going, it was totally jammed at that point. So it almost took us almost 20 minutes to keep trying very cautiously, but then it was not working. We tried propofol, around the sheath, not working. So then at that point, we thought we need to go ahead with the balloon, dilate the iliacs and then try. It was a highly calcified iliacs, as we can see. At this point, although we took quite a significant size balloon, it was 8 into 40 or 9 into 40 peripheral balloon. We dilated, it was calcified. We were prepared that if need be, we'll go with the stent and then go ahead. So up till this point, we were all ready for that. After ballooning, we gave it another try to maneuver the valve across that iliac. And again, with a lot of difficulty, it took us almost 15-20 minutes. Slowly and gradually, it just went ahead. And then once we have crossed that iliac, it was all a smooth run. And then we placed the valve, and it looked all okay after this point. So what I mean to say is the hostilities may not be in the aorta, it may be in the vascular access, which are equally important to figure out while planning such cases. So later on, it was closed by proglides, and this is the echo, very trivial AR. The results was fine, mean gradient of 4 only. So tricks used, pull and push technique, be very patient, keep trying slowly, gradually, don't push it hard, it can perforate. Keep trying. You can smear the propofol around the sheath or the delivery catheter system for the valve. Glycerin is another option, and dilate the vessel with a balloon, or if need be, peripheral stent the vessel and then go ahead. So transcatheter aortic valve replacement in low coronary ostial height. This is another case I'm showing. 71-year-old female, critical aortic stenosis, considered as a suitable candidate for TAVR since, again, she was very high risk. She had very bad lungs. We waited even for TAVR to get her lungs better, and did it after a few days of admission. The problem is the biggest red flag visible in these parameters is the coronary ostial height less than 10 on the left side. So, and also the sinus of Valsalva, if you can see, were not really spacious. So 25 and 23.9 on the RCC side. So not really great. It's a constrained aortic anatomy with low coronary ostial height. So these are the cases where we have to be really careful while deploying the valve. One way is we can just get into the left main, put a wire and a stent in place prophylactically. If need be, we go ahead with the stenting, creating a chimney there. Another way is this, what we did. So this is the echo, and this is the procedure. So valve crossed, and this is what is required to be done in such situations, that while we are dilating the valve, we take a aortogram and see which way the balloon is opening up. It's opening up towards the left main, or the valve leaflet will engulf the left main, although it's not a sure shot sign because balloon will not be of the magnitude as the valve is, the diameter wise, but it gives us a clue. It gives us a clue that as to what complexities we can encounter while we are deploying the valve. So this is this step, the second step is very, very important. And then obviously once we have made up our mind that we go ahead and again, so the idea of using a self-expanding valve in this situation is is of immense value because we can always retrieve the valve. So now once it is 80% deployed and still we can retrieve it, we are still watching very carefully. We took a lot of time here to watch the leaflet. See, the thickened leaflet is going towards this as per height is concerned, but sinus of Valsalva is still giving us some space there. So there is a chance we may get away, although again, as I mentioned, it's not a sure shot sign, but yes, we get a lot of clue here if we may land up in big trouble or not. So valve deployed, and this is the valve, and as I mentioned, there is some space of sinus of Valsalva, which is giving us a relief, and our flow was good, and we got away without any big problems.
So,
Another case.
Rajneesh, you'll be out of time now.
Yeah.
We have spent 10 minutes.
Yeah.
So I think you could sum up. Yes.
Yeah. So I think I'll come to the last slide. I'll skip the last case. This was also interesting, but just learnings are that no case is simple or complex. We have to do a exquisite or meticulous planning before doing a tower. The CT room data is very, very important. The access points are very, very important, and we really require a good team to execute such procedures. Primary operator and secondary operator, they are of all equal value, and if we look at all these points very carefully, I think we can have the best outcomes with tower. Thank you.
Thank you, Rajneesh. And you were showing such interesting cases that I didn't want to interrupt you, but unfortunately we're running late. So well done. That was real good learning. Thank you.
Thank you.